So today we are going to start general pharmacology, and see, this is something that we have read in detail in our second year of MBBS, but we tend to forget it. Why I am going to discuss this topic with you today is not because there are a lot of questions asked from this topic, because this basically forms the backdrop of every drug that we are going to discuss in the next coming few weeks. So if you don't know general pharmacology, you don't know the transport of the drug, you don't know the cell membrane, you don't know how drugs act, then basically you are always in the dark, you're trying to mug up things. So this is the basis of everything. Okay, we have Rajeshri as well. Welcome Rajeshri. Right? So first we'll start with what are the questions that have been asked, and not many questions have been asked, and these are all vague questions. General pharmacology of the drugs, no question has been asked from this topic, but this is something that forms the basis of everything. Placental transfer of drug and its implications is a very, very important topic. So once we understand, we'll go through the general pharmacology step by step. In between, we will discuss how placental transfer gets affected. Hypoproteinemia and anesthetic agents, context sensitive half time, and anesthesia and neurotoxicity. All right. These are the questions from general pharmacology that have been asked in the exam. But I am going to start with the discussion of the basics of general pharmacology. Let's start with the cell membrane and the structure. Cell membrane and the structure. And this, since there is no question asked from this topic, so this is for your understanding. We know that cell membrane is a lipid. It's a phospholipid, which is in the form of a bilayer. It is in the form of a bilayer that has a thickness of 10 nanometer. It has a fluid mosaic kind of a model with a hydrophilic exterior and a lipophilic interior. So what happens is, it is like this. The lipophilic molecules, they come and attach each other on the inside, while the hydrophilic molecules, they are on the opposite side. So it's a lipid bilayer. And then there are multiple channels, proteins, there are glycoproteins which are attached, which forms the reason or the pathway for the drug to enter inside the cell membrane, or the things that are inside the cell membrane to go out, right? So it's a lipid bilayer, that is what we say, which is made up of phospholipid, and it is 10 nanometer thick. Hydrophilic is on the outside, lipophilic is on the inside. This is called as a fluid mosaic model. This is called as fluid mosaic model. All right. What are the methods by which drugs are crossing this cell membrane? What are the methods by which drug crosses cell membrane? So most of the drug, and we are talking about most of the anesthetic drug, they use this passive diffusion. Most anesthetic drugs. That is why they are very fast in onset. Most anesthetic drugs use passive diffusion. That is simply they go from one part to another part, either from outside to inside or inside to outside, depending on their obviously concentration gradient. That is called as passive diffusion. Passive diffusion. Then you have something called as facilitated diffusion, which is helped by other. Then you have selective facilitated diffusion, where there is only selective diffusion of a molecule. Then you have a primary active transport, where there is a pump, which is an active pump that will use some energy and then push a substance against its concentration gradient. That is called as primary active transport. Primary. Secondary active transport is somebody else is going to consume the energy, some other pump is going to use the energy and then cause a transmission of the drug in this aspect. That is secondary active transport. And then you have endocytosis, exocytosis, which is a part of pinocytosis, where the cell membrane drinks the substance by making a vacuole around it, it goes inside. That is pinocytosis. These are the different methods of drug transfer across membrane. But remember, most anesthetic agents, they use passive diffusion. Most anesthetic agents use passive diffusion. Most anesthetic agents use passive diffusion. Let's look at the factors affecting this rate of diffusion across the membrane. Factors affecting the rate of diffusion. The first is molecular size. First is molecular size, and we know that rate of diffusion is inversely proportional to square root of the size. This is called as Graham's law. This is called as Graham's law. That means more the size, less is the rate of diffusion. Less the size, more is the rate of diffusion. And we'll see later on that if you are using drugs, then the size, if it is less than 1000 Dalton, then it is very easily passes the cell membrane. If it is more than 1000 Dalton, then it is very difficult. But water and liquids which are freely accessible, solutes which are freely accessible, are usually 30 to 100 Dalton. So they are so small that they can pass freely through the plasma membrane. Then obviously concentration gradient. Any agent will always move from an area of high concentration to low concentration, and that rate of diffusion is dependent on Fick's law, which is that basically it's directly proportional to the difference in the concentration between outside and inside, right? Ionization. Ionization, and remember about ionization that it is the unionized fraction which crosses cell membrane easily. This ionization becomes very, very important in drugs which are weak acids and weak bases. And weak bases, why? Because they are always present in both the form, and it is the unionized fraction which is lipophilic. In general, lipophilic molecules pass through plasma membrane easily. Lipophilic molecules, they pass through plasma membrane easily. So unionized fraction is what causes faster diffusion across the membranes. Faster diffusion across the membranes. All right. Next is lipid solubility. Again, more the lipid solubility, more is the rate of diffusion. More the lipid solubility, more is the rate of diffusion. And finally, protein binding. Protein binding. Now, protein binding is a unique entity. And when we talk about protein binding, then when we give the drug first reaches plasma, right? And we have two types of plasma proteins. Which are the two types of plasma proteins? Albumin and alpha 1 antiglobulin. Alpha 1 antiglobulin. Alpha 1 antiglobulin. Now, albumin binds to acidic drugs, while alpha 1 antiglobulin binds to basic and neutral drugs. Now, protein binding is of lot of importance for drugs that are highly protein bound. Implication for high protein bound drug. See, we talk a lot about protein binding and its effect. But what is this protein binding? So when a drug reaches the systemic circulation, it first comes in contact with these proteins. Okay, I'm just coming in a minute. Okay, just a minute. Wait for 2 minutes. All right. I am sorry. There was a there was a child emergency. Just a second. Yeah. Hi, you're here. I'm sorry for that. But when you have a 3-year-old in your home, then sometimes it becomes difficult to make them understand. So yeah, she was here and she had some temper tantrum. I'm really sorry for that. All right. Yeah, so we are talking about protein binding. So what is this concept of protein binding? So the moment the drug reaches the systemic circulation, it comes across two types of protein. If the drug has a acidic nature, then it binds to albumin. If the drug has a basic or a neutral nature, it will bind to alpha 1 antiglobulin. Okay. Now, if a drug is highly protein bound, remember the action of the drug is dependent on the free drug. Action is dependent on free drug concentration. That is the unbound drug, one that is not bound to plasma protein. A drug that is bound to plasma protein is not available for the receptor to act. A drug bound to plasma protein is not available for the receptor to act. Okay. So action is only dependent on the free drug concentration in the blood. Free drug concentration. But it is the equilibrium between the bound and the unbound drug that decides the free drug concentration. So what happens? Bound drug constantly becomes free drug, and when free drug is more, it will go and become bound drug. So there is a constant flux between the two. Now imagine if there is decrease in plasma proteins. Let's, for an example, say a condition where there is liver cirrhosis, which is leading to hypoproteinemia. Liver cirrhosis leading to hypoproteinemia. Now what will happen? The bound fraction of the drug will decrease in bound fraction, which will lead to increase in free drug. Now if the drug has low therapeutic index, then this hypoproteinemia can lead to drug toxicity. This can lead to drug toxicity only when the drug is highly protein bound, because this will become clinically significant only if the drug is highly protein bound. Example, warfarin. Highly protein bound drug which can cause if there is a liver failure, then the action of warfarin increases because more free drug is available. Sometimes it can cause drug toxicity, right? This is the effect of hypoproteinemia on the action of protein binding, which is being asked as a short note. There is nothing much to write in it. You just have to describe that the drugs are bound to plasma protein, and then acidic drugs are bound to albumin, and basic drugs are bound to alpha-1 antiglobulin. And this is what happens when there is sudden hypoalbuminemia, or there is, say, hypoproteinemia because of, say, malnutrition, or there is a liver cirrhosis leading to these things. So the action of the drug will increase. Now you will require lesser dose of the drug for the action. But there is something very unique that happens in hypoalbuminemia. What happens is, when there is hypoproteinemia, then usually there is increased volume of distribution because of increase in the circulating volume, because now the proteins are not keeping the water intact, so there is a lot of water, so increased volume of distribution of the drug, so you will require higher induction doses, or first dose required would be higher induction doses. First dose required would be higher. First dose required would be higher. So although subsequent doses have to be less because there will be more free drug available because of less proteins, but initially because of higher volume of distribution you require higher induction doses. This is the effect of hypoproteinemia on drug action. Next we move on to absorption. Absorption, how the drug gets absorbed from its site of administration. So there comes the routes of administration. I have divided it into, for ease, routine routes of administration and special routes of administration. Special is not something that we commonly use. Routine, we commonly use inhalational route. As anesthetists, we use inhalational, IV, oral. Then you have intrathecal, epidural, buccal, sublingual, and rectal. All these three, there is bypassing of first pass metabolism. Bypassing of first pass metabolism. Special are transdermal drug delivery system, and subcutaneous administration. Now in anesthesia, subcutaneous administration, we come across low molecular weight heparins. And transdermal delivery is for sustained release patches. Now these patches can be fentanyl patches, buprenorphine patches, diclofenac patches. So these patches can be of different drugs where you want a constant delivery of the drug over a long period of time, where there is no jhanjat of giving the drug orally or parenterally, and so the patient just keeps on getting the drug. That is usually used for chronic pain conditions or even in acute pain. But we will discuss transdermal drug delivery. I'll make a short note for you and we will discuss transdermal drug delivery. Very interesting. All right. Let's come to the most common route that we use is IV. Most common route is IV. What is the advantage? Fast action, because there is 100% bioavailability. There is 100% bioavailability. But the disadvantage is because there is fast peak, so more side effects. Fast peak levels, so more side effects. Fast levels, so more side effects. Are you guys here? Kundan, CD4, Rajeshri, Ayushi, Lavanya. Are you guys here? Now, what is this bioavailability? What is this bioavailability and extraction ratio? Now, this is not something that they have asked in theory to us, but this is definitely something that they are going to ask you in Viva. This is a very common question, especially bedside. If you have a liver disease patient, then they will always ask you bioavailability, first pass metabolism, extraction ratio. Now, we know what is bioavailability. It is the fraction of the drug reaching systemic circulation compared to same dose given IV. What is bioavailability? Great. It's good to see so many students coming live. It's very nice. It is the fraction of the drug reaching systemic circulation compared to the same dose given IV. So when you compare it with IV, so 100% bioavailability when you give IV. So IV, same. Oral administration has least bioavailability. Oral administration has least bioavailability. What are the factors affecting bioavailability? What are the factors that will affect bioavailability? First is pharmaceutical preparation. What sort of a preparation? If you are using smaller molecules, smaller size of the molecules, better bioavailability. Bigger molecules, lesser bioavailability. Physiochemical interaction. You are using an acidic drug is an acidic environment, more unionized fraction, faster bioavailability, faster absorption. If you are using a basic drug in an acidic environment, less bioavailability. Patient factors, local pH, gastric motility, and first pass metabolism. First pass metabolism. Usually, whenever they will ask you bioavailability, they would want you to know about first pass metabolism. Now, what is this first pass metabolism? So, you have given a drug orally. So, drug reaches gut. From gut, it goes absorbed and goes into portal vein. Portal vein will take this drug into liver, where it will metabolize the drug. So, what happened? Before the drug reached systemic circulation, there is loss of the drug by metabolism. That is first pass metabolism, and obviously decreases bioavailability. Decreases bioavailability. Decreases bioavailability. So any factor that is going to cause enzyme induction, that is increase the activity of liver enzymes, enzyme inducing agents will decrease oral bioavailability. isn't it? It will decrease oral bioavailability. Because if there is enzyme induction, then the first pass metabolism will increase. If the first pass metabolism increases, then automatically oral bioavailability decreases. Already oral bioavailability decreases. Enzyme inhibition. Enzyme inhibition will increase oral bioavailability. Will increase oral bioavailability. Will increase oral bioavailability. ठीक है? So this is bioavailability. Next is extraction ratio. What is extraction ratio? It is the fraction of the drug removed from blood by liver. That is for liver, metabolism by liver. Fraction of the drug removed by the liver from the blood. There are three factors on which extraction ratio depends: hepatic blood flow, uptake in hepatocytes, and enzyme activity of those hepatocytes. Now there are drugs that fall in one of the three categories. Categories of drugs based on hepatic extraction ratio. They fall in three categories. What are they? First category is rapid uptake and high hepatic metabolism. Rapid uptake and high hepatic metabolism. Examples of these drugs are propofol, lignocaine. Propofol and lignocaine. So they are very high in uptake in the hepatocytes, as well as they are getting very fast metabolized. So here the drug concentration will be independent of protein binding. It will only depend on hepatic blood flow, because it doesn't matter, because the drug will get into hepatic circulation very fast and very fast metabolism. So saturation will not happen in the hepatocytes, and therefore what will happen is that the drug concentration is independent of protein binding and depends on hepatic blood flow. Second type of drug is low metabolism and high protein binding. Example, phenytoin, diazepam. Here drug concentration will be affected by protein binding, not so much on hepatic blood flow. So drug concentration influenced by protein binding and not on hepatic blood flow. And then of course you will have the third class of drug where there is low uptake and low metabolism. So these drugs will have no effect on both protein binding as well as hepatic blood flow. Protein binding and hepatic blood flow. So extraction ratio is for the metabolism by the liver, while bioavailability is what is the percentage of the drug that reaches systemic circulation as compared to if you give the same dose of the drug IV. Okay? So we have already written buccal, sublingual, nasal, rectal routes. They bypass the first pass metabolism. They directly go into systemic circulation. That is why we use rectal suppositories, diclofenac and all, so that you have better bioavailability of the drug. Let's talk about inhalational route. We are going to discuss this route in great detail, but we have to understand that when we give a drug inhalationally, then we are wanting two types of action. Either we are wanting local action or we are wanting systemic action. And it will all depend on the size of the particle that we are using. If you are using more than 1 micron size, then it stays in the upper airway, causing local action. Example, inhaled bronchodilators, inhaled or nebulized bronchodilators. If the size of the particle is less than 1 micron, they will reach till the alveoli. So systemic action, volatile agents. So far so good. Everybody is with me. You are trying to understand. These are the things that they expect you to know, but they will never teach you. Nobody actually teaches general pharmacology anymore, isn't it? We have to only dive into the books and go into our second year, and sometimes it's no harm if you open up KD Tripathi and you go through these. But you know, all standard pharmacology textbook of anesthesia, they all have chapters on general pharmacology, and it is always worth giving them a read. The reason is simple. This forms our basic understanding of all the drugs. So you know these things. These are all theoretical things that are going on. But then someday somebody will ask you, okay, when you give a volatile anesthetic agent, what is the route of administration? You will say inhalational route. So the examiner will say, okay, but you also give salbutamol puff. Is that also inhalational route? But then that acts on bronchus while this acts on brain. How is that possible? And you will get caught up. Okay, how is that happening? You will also start thinking, how is that happening? So this is how it is happening, because the size of the particle is less than 1 micron. So it will go deeper. It will reach the alveoli, and from alveoli it diffuses. And see, this is the largest route of administration of the drug. The total surface area of pulmonary capillaries is 70 meters square, which is huge. So and that is why in CPR, if you cannot get an IV access, you do not have an intraosseous access, then endotracheal is your route of administration, because if you push the drug through the endotracheal tube and you give an ambu bag, it distributes in the alveoli, and from there it gets absorbed. But you use a higher dose because you don't know how much of that drug is getting absorbed, right? So this is the reason why we use something like an endotracheal route of administration in case of CPR. All right. So this was about absorption. We know pharmacokinetics is divided into absorption, distribution, metabolism, excretion, also remembers as ADME. ADME, and absorption, distribution, metabolism, and excretion. Let's now come to distribution. And in distribution, we are going to discuss a very important aspect, that is the placental transfer of the drug, which is a very important question. Also, it is something that you should know, because if at all you are giving general anesthesia to a parturient, we give it less. So we tend to forget this topic a lot, because we give so much of spinal these days. For everything we have spinal. Therefore, it is very, very important that you really remember which are the drugs that are going to affect the fetus. Okay. So we know how drugs can cross different membranes, right? Now, depending on the distribution in the membranes, you can divide drugs into three categories. One that are confined to plasma, which are large molecules. A type that we have discussed in detail is colloids. They stay in the plasma because they are large molecules, so they don't go anywhere. Warfarin. Why? Highly protein bound. Highly protein bound. Then you have drugs with limited distribution. Drugs with limited distribution, which are usually non-depolarizing muscle relaxants, which are polar, that is ionized, and they are large and they are poorly lipid soluble. So some amount will get distributed, but not much. And then you have drugs which are extensively distributed. Which are highly lipid soluble drugs. Highly lipid soluble drugs. Okay, highly lipid soluble. This is based on distribution, confined to plasma, limited distribution, extensive distribution. Let's discuss placental transfer of drugs. Now this can come as a 10-mark question as well. It can come as a 5-mark question as well. Usually the question comes is how is there is placental transfer of the drugs and what are its anesthetic implications. So we are going to discuss it like a 10-mark question. If a 5-mark question comes, you write what you remember, then it automatically becomes a 5-mark question. Why is it important for us to know placental transfer of the drugs? It is important because important aspect of the drug administration. To mother, which affects the fetus. Whatever drug that you are going to give to the mother, you have to know its effect on the fetus. That is why it is important for you to know the placental transfer of these drugs. Placental transfer of these drugs. Let's go into the basics of structure and function of placenta. Very basic for exam writing. At term, placenta is oval and flat. It has a diameter of 18.5 centimeters. It has a weight of 500 grams. And the most important part of placenta, that is the intervillous space, holds up to 350 ml of maternal blood. (350 ml of maternal blood. Now we know that human placenta, every species has a different type of placenta. Human placenta is hemochorial in nature. Human placenta is a hemochorial placenta. What do you mean by hemochorial? That the fetal tissues are bathing in maternal blood. Fetal tissues are bathing in maternal blood. If you look at this, see, this is a complete, what you can say, labeled image of a placenta. Okay? Nobody is going to come and ask you to label this image. Just remember, see, this is the amniochorionic membrane. This is the uterus. From uterus, there are spiral arteries which are getting embedded. This is the fetal circulation vessels, and this is the intervillous space. From this interface, there is transfer of drugs, molecules, hormones, fluid, blood from maternal to fetal aspect. From maternal to fetal aspect. Okay. So this image is for you. You can also Google this image just for your understanding. Nobody is actually going to come and ask you, because I don't think any anesthetist knows what is the function or what is the importance of this thing. Okay. But the most important thing is the function of the placenta. Most important thing is the function of the placenta. Why is placenta placed? So the placenta has three functions. The first is it acts as a barrier between mother and the fetus, but it's sort of an imperfect barrier that lets most of the substances through. Most of the substances through. It's an imperfect barrier that will allow most of the substances to pass. It also has metabolic capacity. Placenta has embedded cytochrome P450 enzyme that will decrease some drugs in reaching the fetal circulation. Okay, that is for metabolism. Second is hormonal. This is very important. Placenta produces and then dispatches lot of substances. It converts steroids to progesterone and estrogen. It makes proteins and peptide hormones. like HCG and HPL. HCG is human chorionic gonadotropin and HPL is human placental lactogen. These are the two main hormones that are made and secreted by the placenta. And then it has obviously the transport function. And we know there are 4 types of transport: passive diffusion, facilitated transport, active transport, and pinocytosis. So these are the functions of placenta: barrier, hormonal, transport. Just complete this list.